Thank you. Hello, everyone, and welcome again to our presentation on addressing ADA obligations and access to care in the justice system. My name is Dustin Bartley. I'm a senior policy analyst with the Council of State Governments Justice Center, and I will be helping to facilitate today's session. Please note that the session is being recorded, so it can be shared with other grantees who could not be in attendance today. We'll also email a link to this recording to each attendee once it's posted to our website. Today's session is being hosted by the Council of State Governments Justice Center and is funded through the Bureau of Justice Assistance. Carly, would you advance to the next slide, please? Here's a brief outline of today's presentation. We'll start with short introductions of our speakers and then provide an overview of the Council of State Governments Justice Center and the Justice and Mental Health Collaboration Program. We'll then provide a short overview of the Sequential Intercept Model, followed by a presentation on ADA enforcement across all intercepts. We'll then be joined by 4 current Justice and Mental Health Collaboration Program, or JMHCP grantees, to share about their work to improve access across all intercepts, and we'll of course allow time at the end of the session for questions and answers. And due to the size of today's audience, we'll ask that you use the chat box to post your questions, and also due to the number of speakers, we'll plan to address questions at the end of the presentation once each of our panelists have shared. Next slide, please. Today, we're happy to be joined by a number of speakers to help us better understand ADA requirements and hear firsthand examples of work occurring across each intercept. With us today, we have Haley Van Aram, a trial attorney in the Civil Rights Division, Special Litigation Section with the U.S. Department of Justice. Commander Curtis L. Graves Sr., the Director of Strategic Initiatives with the City of Mobile, Alabama Police Department. Dr. Cindy Gibson, Associate Director of Crisis Services with Alta Point Health. Dr. David Geyer, a corrections therapist with Kittitas County Sheriff's Office in Washington. Stephanie Turner, a forensic program manager, excuse me, with the Behavioral Health and Justice Division in the City of Philadelphia. Kelly Greenwald, Regional Reentry Coordinator with Yes Care in Philadelphia. Jacinta Reason Johnson, the Behavioral Health Reentry Coordinator, also with Yes Care in Philadelphia. And Dr. Gary Cuddeback, Interim Dean and Professor, Associate Dean for Research, and Interim Associate Dean for Faculty Affairs work at Virginia Commonwealth University, representing our grantee, the University of North Carolina. Next slide, please. The Council of State Governments Justice Center is a national nonprofit, nonpartisan organization that combines the power of a membership association serving state officials in all 3 branches of government with policy and research expertise to develop strategies that increase public safety and strengthen communities. Next slide, please. We work by bringing people together, by driving the criminal justice field forward with original research, by building momentum for policy change, and by providing expert assistance. Next slide. Our goals are to break the cycle of incarceration, to advance health, opportunity, and equity, and to use data to improve safety and justice. Next slide, please. The Council of State Governments Justice Center is committed to advancing racial equity internally and through our work with states, local communities, and tribal nations. We support efforts to dismantle racial inequities within the criminal and juvenile justice systems by providing rigorous and high-quality research and analysis to decision makers and helping stakeholders navigate the critical and at times uncomfortable issues that data reveal. Beyond empirical data, we rely on stakeholder engagement and other measures to advance equity, provide guidance and technical assistance, and improve outcomes across all touch points in the justice, behavioral health, crisis response, and reentry systems. Next slide, please. And the Justice and Mental Health Collaboration Program, or JMHCP, promotes innovative cross-system collaboration and provides grants directly to states, local governments, and federally recognized Indian tribes. It is designed to improve responses to people with mental health conditions and substance use disorders who are involved in the criminal justice system. Next slide, please. And we'll now move into a brief overview of the sequential intercept model. And next slide, please. The sequential intercept model, often seen abbreviated as SIM, was developed over several years in the early 2000s by Policy Research Associates, or PRA. The sequential intercept model was developed as a conceptual model to inform community-based responses to the involvement of people with mental and substance use disorders in the criminal justice system. And Carly, could we go back about 2 slides? No worries. And as we're getting back, I'll go ahead and provide just a brief overview of the model to help set the stage for the remainder of our presenters today. At each of the intercepts, the model identifies potential community-based responses for individuals with mental and substance use disorders in the criminal justice system. At intercept 0, or community services, you can see crisis lines and the crisis care continuum. Potential community-based responses at this intercept include mobile crisis outreach teams and co-responders, emergency department diversion, and police behavioral health collaborations. At intercept 1, law enforcement, you can see 911 and local law enforcement. Potential responses at this intercept include dispatcher training, specialized police responses, and intervening with frequent utilizers to provide follow-up after the crisis. At intercept 2, initial detention and initial court hearings, you can see initial detention and the first court appearance following arrest. Potential responses at this intercept include screening for mental and substance use disorders, data matching initiatives between the jail and community-based behavioral health providers, and pretrial supervision and diversion services to reduce episodes of incarceration. At intercept 3, jails and courts, you can see specialty court, jail, and dispositional court. Potential responses at this intercept include include treatment courts for high-risk, high-need individuals, jail-based programming and healthcare services, and collaboration with the Veterans Justice Outreach Specialist from the Veterans Health Administration. At intercept 4, reentry, you see both prison reentry and jail reentry. Potential responses at this intercept include transition planning by the jail or in-reach providers, medication and prescription access upon release from jail or prison, warm handoffs from corrections to providers to increase engagement in services, and case managers that pick an individual up and transport them directly to services to increase positive outcomes. And at intercept 5, community corrections, you see both parole and probation. Potential responses at this intercept include specialized community supervision, caseloads of people with mental disorders, medication-assisted treatment, or MAT, for substance use disorders, and access to recovery supports, benefits, housing, and competitive employment. And as we transition into Haley's presentation, you'll hear more about the application of ADA requirements at each of these intercepts. Carly, would you advance to the next slide, please? And with that, I will turn the presentation over to Haley.
Hello, good afternoon. Thanks so much. I'm excited to be here. My name is Haley Van Arum, and I am a trial attorney with the Special Litigation Section of the Civil Rights Division of the Department of Justice. And Carly, you can go ahead and go to the next slide. Thank you. So our office enforces the Civil Pattern or Practice Police Misconduct Statute, as well as the Americans with Disabilities Act. We handle solely systemic investigations and cases. And the Civil Rights Division has really focused efforts recently to address the critically important issue of needless criminal justice system involvement for people with behavioral health disabilities. We know that people with mental illness and substance use disorders make up a disproportionate share of police interactions in the jail population. And we know that carceral settings are not conducive to and often exacerbate mental health recovery, mental health symptoms. And so, but we still find that people with behavioral health disabilities are often pulled deeper and deeper into the criminal justice system through a revolving door of repeated jail admissions, minor probation violations, and continued criminal justice system involvement, with very few off-ramps into community-based services that we know can stop the cycle or prevent it from occurring in the first place. And so to the extent that discrimination is perpetuating or contributing to the cycle, it's a priority for the Civil Rights Division to address it. And so I'll give you a brief overview of our work in this area with some examples across many of the intercepts. We can go ahead to the next slide. Okay, so here are I'll talk about many of the intercepts today and provide some examples. Go ahead to the next slide. Okay, so just briefly wanted to give an overview of the Americans with Disabilities Act requirements in this context. The part of the act that I'll be talking about today is a requirement that prohibits discrimination by state and local governments in services, programs, and activities on the basis of disability. The ADA requires that services, programs, and activities be provided in the most integrated setting appropriate to individuals. And it also requires effective communication, accessibility, housing integration, and access to services, programs, or activities in correctional facilities. It also requires reasonable modifications in policies, practice, and procedures necessary to avoid discrimination. And I'll talk a little bit more about what some of those reasonable modifications can be at various intercepts. Next slide, please. Okay, so starting with Intercept 0, community services. Go ahead to the next slide. So I wanted to talk first at this intercept about our Olmstead enforcement. We enforce Olmstead, which is a Supreme Court case called Olmstead versus LC, where the Supreme Court, the United States Supreme Court, found that the Americans with Disabilities Act requires what's called an integration mandate. It requires that services be administered in the most integrated setting appropriate to the individual's needs. And so, as we sort of enforce, and in these cases and in all of the cases that I'll be talking about today, we have, long-lasting cases that kind of take up a number of different phases. We conduct investigations. Once if we receive a complaint that a jurisdiction is violating the law, we conduct an investigation to determine whether there's reasonable cause to believe that the law is being violated, such as the ADA. If we find that there is, we issue a public document called a findings report, and we typically engage with negotiations with the jurisdiction to try to come to a resolution like a settlement agreement or a consent decree to address those violations of law that we found. If the negotiations doesn't work, we can bring a lawsuit and engage in litigation. But frequently we are able to come to an agreement, and then we work to enforce the agreement and make sure that the violation is remedied. So the different examples I'll talk about today are at varying stages, but I thought it might be helpful to kind of provide some of that context. Okay, go ahead to the next slide. Okay, so I wanted to provide an example in our Olmstead enforcement of Alameda County. We issued findings regarding Alameda County in California in 2021. Our investigation found that the county fails to provide services to individuals with mental health disabilities in the most integrated setting appropriate to their needs. It was unnecessarily institutionalizing people at a John George Psychiatric Hospital and other facilities. On any given day in Alameda County, hundreds of people are institutionalized for lengthy stays at one of the several large locked psychiatric facilities in the county, or hospitalized at John George Psychiatric Hospital, and others are at serious risk of institutionalization. And this is due to a lack of community-based services, mental health services. Without connection to those services, people are returning to psychiatric hospitals again and again. And we also found that this lack of community-based services also contributes to people's risk of incarceration. We found that Alameda County can expand its current community-based services. And this is really what we're talking about at that, Intercept 0. Services such as crisis services, permanent supported housing, peer support services, to effectively serve people with disabilities who are being institutionalized. And that those services were alternatives to institutional care and are cost effective. This investigation also looked at the Santa Rita Jail in Alameda County. We found that they failed to provide constitutionally adequate mental health treatment, which resulted in a worsening mental health conditions for prisoners with serious mental health needs, repeated stays at John George, and at times serious physical harm and death. In particular, we found that the jail was denying prisoners with mental health disabilities equal access to programming and transition services because of their mental health classification. And so that kind of gets into some of the later intercepts as well. But so, as a result of all of this, we found that many adults who rely on Alameda County for mental health services are without access to services that would allow them to recover, and they instead end up cycling in and out of psychiatric institutions or incarcerated. So we're currently in negotiations with Alameda County to resolve these findings, and we're hopeful that we'll be able to enter into a settlement agreement that would really require additional community-based services to prevent this cycling. Okay, you can go to the next slide. Okay, another example I wanted to talk about is our investigation into Maine. In 2022, after an investigation, we issued findings that the state of Maine fails to provide children with behavioral health needs with integrated services. We found that children are being segregated in psychiatric hospitals and residential treatment facilities due to a lack of community-based services. And some of these services are things like intensive case management and community-based crisis services. Again, those services at Intercept 0 that can really divert people. And we, in addition to sort of psychiatric hospitals and residential treatment facilities, we found that the state's juvenile detention center, Long Creek, is also a segregated setting. Children were routinely incarcerated there expressly for the purpose of receiving behavioral health care there due to insufficient services in the community. We found that if sufficient behavioral health services were available in the community, children who were appropriate for such services could await trial or serve their sentences at home with their families, just like children without behavioral health needs can. And that was a violation of the ADA. So, and along with this, Maine and other entities have released multiple public reports that the current system is relying on that juvenile detention facility as a de facto psychiatric facility because it lacks therapeutic options in the community for children. So again, as in Alameda County, we're currently in negotiations with the state of Maine to resolve these findings. But this is another example of how the Americans with Disabilities Act really applies to those community-based services that we want to see at Intercept 0. Okay, you can go to the next slide. Okay, quickly, I wanted to talk about some of our ongoing investigations. In Kentucky, we have an open investigation into the Commonwealth of Kentucky, and whether they provide community-based services necessary to avoid needless psychiatric admissions to people in the Louisville area in particular. I'll discuss this later in conjunction with Intercept 1, but we also had an investigation into Louisville Metro government and LMPD regarding unnecessary deployment of police to behavioral health calls. And that really kind of so those both investigations really involve a similar population, and it really highlights the different obligations that different jurisdictions, state, county, and city have with regard to making sure there's compliance with the Americans with Disabilities Act. Similarly, we have an open investigation in Oklahoma that combines investigations regarding policing and behavioral health services. It looks into the state of Oklahoma and Oklahoma City Police Department to examine whether the state is failing to provide community-based mental health services to people, leading to unnecessary psychiatric facility admissions and police interactions. This is really allowing us to look a little bit more upstream in the cycle of police involvement at those Intercept 0 to see if people are experiencing unnecessary police involvement as a result of the lack of community-based services. And then I also wanted to highlight that in some other ongoing work we have, jurisdictions have really invested in crisis services as a result of some of this work. For example, in Georgia, we have an Olmstead settlement agreement that prompted the state to create 131 mobile crisis teams with statewide coverage, serving both people with serious mental illness and people with developmental disabilities. Recent data show that the teams are dispatched about 2,000 times per month, often diverting people from contact with a hospital or the police. Our agreement also prompted the state to create over a dozen crisis walk-in centers and 36 mental health crisis apartments that can serve more than 80 people at a time, and those are located in community settings across the state. Similarly, another example is New Hampshire. They created their first mobile crisis teams in the state as a result of the requirements in our Olmstead settlement agreement. It required the state to create one team in each of the 3 largest cities in New Hampshire. But given these teams demonstrated bad value, the state later elected to expand mobile crisis team services statewide. And the state reports that mobile crisis team intervention has prevented thousands of people with serious mental illness from having contact with psychiatric or clinical hospital during a crisis. And in recent quarters, less than 10% of the calls handled by mobile crisis also involved law enforcement. So these are just some examples to show, that the services required for compliance with Olmstead and the Americans with Disabilities Act, they really work to divert people from law enforcement encounters and from needless incarceration. Okay, you can go ahead to the next slide. Okay, so the next, I want to talk about Intercept 1, law enforcement. DOJ brings investigations under the pattern or practice law enforcement misconduct statute. And some of this work looks at the intersection of law enforcement and people with disabilities. And I'll talk about a couple examples. Next slide, please. Okay, so I wanted to talk about a couple of really recent examples here. In March 8th, 2023, we issued a finding that Louisville Metro Government and LMPD violates the Americans with Disabilities Act by unnecessarily deploying police to behavioral health calls. We had a number of other findings in our investigation against LMPD, but I'll focus really on this ADA finding today. It was the first time the department found and talked about the unnecessary police responses during behavioral health episodes violating the ADA. We found that LMPD officers are the primary and generally the sole responders to situations involving behavioral health issues in Louisville, even in instances where safety does not require a law enforcement presence. And we found that violated the ADA. The result was to deny people with behavioral health disabilities an opportunity to participate in and benefit from public services that are equal to that afforded others. And that's the language from the ADA. And this really, challenges the premise that police should be the default first responders for behavioral health calls. As it said in the findings report, while some calls necessitate a primary law enforcement response because of violence or threats of violence, thousands of calls per year in Louisville could be safely and more effectively resolved through a response by behavioral health professionals, such as a mobile crisis team, or with co-responding behavioral health professionals, along with appropriately selected and trained officers. The report also discussed not just how police are not always the right response, but how a police response in Louisville was ineffective and harmful. It tied the lack of behavioral health response to criminalization of mental and behavioral health disabilities, because it noted that these encounters with police often led to unnecessary arrest and incarceration. This report also focused on the role of the 911 call center, talking about how the call center's operations weren't ensuring that call takers were obtaining adequate information from callers regarding behavioral health crisis, or sufficiently memorializing that information for dispatchers and for responding LMPD officers. So I just wanted to share an example from the Louisville investigation. We talk about a number of people that this violation affected, that we saw in our review. And one example is a Black man who had an apparent behavioral health disability who experienced more than 25 LMPD encounters in under 2 years. In one October 2021 incident, LMPD officers responded to a report of him. It was a report of a disorderly person panhandling. They found the man walking in the street with his shirt off. He really spoke to officers in a way that was difficult to understand. And it was sort of clear that the officers knew him and knew that he likely had a behavioral health disability. The officers took him to the hospital, but they also charged him with possessing drug paraphernalia. Unfortunately, he died on January 9th, 2022 in the Louisville Metro Detention Center. He had been arrested on January 5th, 2022 and charged with criminal trespassing and failure to appear on previous charges. And, we found after reviewing all of these encounters, including the 2 that I just mentioned, the October 2021 incident, as well as the final incident he had in encountering LMPD, that they could have been handled by behavioral health focused response, either concurrently with law enforcement or in some cases without police involvement at all. Okay, you can go ahead to the next slide. And so I said earlier that a requirement of the ADA is that a jurisdiction makes reasonable modifications. And in Louisville, we found that that LMPD could make reasonable modifications to avoid this discrimination that we talked about in the report, such as deploying alternative responses, enhancing coordination with the crisis hotline and other services, and modifying LMPD's CIT program, which is the program where officers are trained regarding behavioral health disabilities. Just want to emphasize this is a really fact-specific inquiry. What may be reasonable in one jurisdiction may not be reasonable in others. So in Louisville, we entered into an agreement in principle with the Metro government, who committed to negotiating to resolve the department's findings through a court enforceable consent decree with an independent monitor, but the details of that have not been worked out yet. Okay, you can go to the next slide. Just briefly wanted to touch again on another very recent investigation, the findings that we issued in June. We issued findings regarding the Minneapolis Police Department. Again, these findings were on a number of different issues, but I'll talk only about the ADA issues today. We found that Minneapolis violated the ADA by relying on MPD officers to respond to people with behavioral health disabilities who pose no threat of harm. We also noted that the city's treatment of people with behavioral health disabilities is really in stark contrast to the experience of people in need of medical assistance who receive a response from trained emergency medical services professionals. Again, as in Louisville, the city's failure to provide appropriate emergency response services for people had really grave consequences, including serious injury and death for Minneapolis residents. In Minneapolis, we also entered into an agreement in principle with the city and are hopeful we can resolve these findings through a court enforceable consent decree. You can go to the next slide. Okay, I wanted to talk about an investigation that's a bit older in the Baltimore Police Department. Again, similarly, this investigation involved a number and the findings involved a number of different issues, but I'll focus on the ADA here. In 2016, we issued findings that by routinely using unreasonable force against individuals with mental health disabilities, Baltimore Police Department officers were repeatedly failing to make reasonable modifications necessary to avoid discrimination in violation of the ADA. Our findings really focused on both excessive force that was applied under the Fourth Amendment as well as the ADA. We found that officers failed to de-escalate and often escalate instead. We entered into a consent decree with the city. The consent decree required the city to do a gap assessment in the behavioral health service system, really showing the recognition that avoiding these ADA violations starts upstream of police interactions. The city has implemented a 911 diversion pilot with a crisis line in 2021, worked to expand mobile crisis to 24/7 availability. And really looks at better training and policies for dispatch to get more calls diverted from police. So this is another, example of the application of the ADA in this context. Okay, you can go to the next slide. I know I don't have much time, so I apologize. I'm kind of speeding through this. Okay, the next focus was going to be Intercept 3 specialty courts. So next slide, please. Okay, the example I wanted to talk about here is the Massachusetts trial court. We entered into a 2022 settlement, which resolves a complaint filed with the U.S. Attorney's Office that the Massachusetts trial court discriminated against drug court participants taking medication for opioid use disorder. This medication are evidence-based treatments for opioid use disorder, which may increase the likelihood that a person will not continue to use illegal drugs. It reduces withdrawal symptoms and cravings and reduces the risk of overdose death. According to the complaint, as a condition for participating in drug court, participants were ordered or pressured to stop taking their lawfully prescribed medications for opioid use disorder without an individualized assessment by a medical professional. So the agreement we entered into requires drug courts to implement a policy in which only licensed prescribers or opioid treatment programs will make decisions regarding a participant's treatment plan. So I know that's a very brief example, but it's one way that the ADA and discrimination against people with behavioral health disabilities really applies to that intercept, specialty courts. Okay, go to the next slide. Okay, the next intercept I wanted to touch on briefly is re-entry. Next slide, please. Intercept 4. Wanted to touch on briefly our case regarding the Los Angeles jails. And I think, this is another good example of how the ADA applies in various concepts along the different intercepts. We had a 2015 settlement agreement regarding unconstitutional conditions we found in Los Angeles jails. In 2018, we amended the settlement agreement, and it requires clinically appropriate release planning for incarcerated people with a mental illness. The release planning should address housing, transportation, psychotropic medications, medical, mental health, and substance use services, and other social supports. And then it requires the jail to coordinate with community providers, facilitate transition to community services, and help incarcerated people access benefits. So this really kind of shows how important re-entry is for people with disabilities, and how the ADA can really apply at this intercept as well. Okay, you can go to the next slide. Okay, this is the last example I wanted to talk about at Intercept 5, community corrections. Go ahead to the next slide. Okay, the example I wanted to provide was in the United States versus Unified Judicial System of Pennsylvania. The Department of Justice sued Pennsylvania state and municipal court system. After Pennsylvania's motion to dismiss was granted, we filed an amended complaint in May. So this is still very active litigation. Through the lawsuit, DOJ is challenging restrictions imposed by courts within the state's unified judicial system on the use of opioid treatment medication by people in court supervision programs, such as drug courts, mental health courts, and probation programs. And so that's really where it comes into the community corrections. Allegations are that judges in several counties are alleged to have or have had policies banning or limiting the use of medication for opioid use disorder. And so, like I said, this is active litigation. It has yet to unfold, but this is another example of how some of, potentially discriminatory eligibility criteria can violate the ADA. Okay, next slide. Okay, and I wanted to mention, I think I saw a chat coming through about some links and on reports, and I included hyperlinks in the PowerPoint that should link you to the various reports and information on DOJ's website about the various lawsuits and findings reports and settlement agreements. And then I also included a link here. This should be a hyperlink about joint guidance that was very recently issued from DOJ and HHS on emergency responses to people with behavioral health or other disabilities. And this is really, really helpful guidance. I encourage everyone to check it out. It really looks at the importance of diversion during dispatch, identifies the important role of mobile crisis in diversion, and also recognizes the need for ongoing community services because, crisis services are vitally important for diversion, but making sure that ongoing community-based services to treat people with behavioral health disabilities are also very important to keep people out of crisis. Okay, you can go to the next slide. Okay, and then this also has some links in it. More information on the cases. Like I said, the PowerPoint should have the hyperlinks, but you can also go to our websites. These cases are all done by either the special litigation section where I work or the disability rights section. And our websites have information on all of our active cases. So I encourage you to check those out. Also, if you would like to make a complaint regarding an ADA violation, you can do that through the complaint portal, which I've provided a link to. And I wanted to also provide a couple of links to other guidance and technical assistance. The department issued Olmstead guidance, which is very helpful in kind of explaining what the legal standard is under Olmstead and kind of applying it to some different situations. And similarly, the examples and resources to support criminal justice entities is also very helpful guidance. Next slide. And finally, I encourage you to reach out to me, if you'd like to chat about any of this, about any of our work, or share any of the work that you're doing. We're always looking to connect with experts in the field. As I've talked about, we really do a lot of cases in a lot of different contexts. And so we want to stay current and use consultants and experts in our cases and always just connect with others in our area. So in this area, so we can know the most recent practice. So please feel free to reach out. Okay, that is my presentation. I'm sorry, I think I went a little bit over, but I'll stick around if there are any questions at the end.
Thank you so much, Haley, and no worries. I was a little ahead of my scheduled time with the intro, so everything is good. But thank you very much for all this information. This is obviously a huge topic, covering the entire intercept or all of the intercepts, talking about ADA requirements and trying to have some grantee examples. So thank you for all that information. To address the question in the chat, we will email all this information out, both a link to the recording and a copy of the slides, to everyone who registered for this. This will also be posted on the CSG Justice Center's website. Usually takes a week or two to get that posted, but we will send all this information out to everyone. And Carly, would you go ahead and advance the slides, please? And one more. We will go ahead now and move into our grantees that we've invited to share a little bit about the real world work that they're doing without having to be prompted by Haley or the DOJ to increase access to services. So we're joined today by Commander Graves and Dr. Gibson. Would you two like to go ahead and share? And Carly, if you would go ahead and stop sharing, I think they have some slides they would like to present as well.
All right, can everybody see?
We can.
Great. So one thing up front is the two of us, I work for the Community Mental Health Agency, and
I'm with Mobile Police Department. My office is the Office of Strategic Initiatives. So we focus heavily on collaboration, partnerships with our partners that are outside of our discipline.
And I think the thing that that makes things work for us here is the two of us are well, we're like brother and sister,
Yeah,
and very much committed to making this work. We just came back from the CIT conference together. We got new ideas. We're never going to stop. I think that's the most important thing. And so you know, it's about having someone to call, someone to respond, and some place to go. And so we'll use, we're down in South Alabama. Alabama is often known as the 50th, or you know, we're proud. Yeah, we're proud if we're ahead of Mississippi. We consider ourselves doing well, but we're trying to change that. So Dustin showed the sequential intercept model a little while ago, and we kind of go through each piece with some quick slides for the city of Mobile. And so it takes all of us working together. It has to be a partnership of the willing. No one can be voluntold in these endeavors, for sure. So at Intercept Zero, we have a 24-hour crisis hotline for access to care that helps get our crisis response team out and helps coordinate where somebody needs to go. That's also tied to our 988 here, and co-response and mobile crisis are all at Intercept Zero. And a 24-hour behavioral health crisis center that has 15 temporary observation beds or chairs and 6 extended observation beds. And law enforcement can bring someone here in lieu of an arrest. The crisis team responds to about 350 calls per month, and helps to get those people engaged in treatment voluntarily. And so that's, you know, just some quick looks at you know, what we do. Training is very important. Our co-responder model is you know, where we go out together and really try to keep people from being incarcerated when there's, you know, petty crimes or no crime has been committed, but they need mental health help.
Yeah, we can actually share something that we had to do just recently, actually. We got a call and visit from some CID officers out of DOD, one out of Georgia, the other out of North Alabama. And they had a situation where a gentleman made some concerns or some, not necessarily threats, but some overtures toward the Secretary of Defense of our country. And they were trying to locate this gentleman, as well as try to get him in a situation where we could actually assess his mental health. We immediately got together with them to assist them in that. So we collaborated with these individuals outside in the federal government to actually not only to identify him, locate him, but to also get him probated. So that all happened within a matter of about 24 hours, actually. They left us with a great impression of what we're doing here, and actually asked us, could we help them actually facilitate some training?
This is what our crisis center looks like on the outside. The inside is it's community concept, recliner based, and the goal is to get people treated and stabilized quickly and back out into the community with a full complement of support programs. And a big part of Intercept Zero for us is prevention and talking about mental health in the community and being advocates. Commander Graves operates a podcast with one of our participants' husbands, and they frequently talk about mental health and how we can work together.
Yeah, that gentleman is Commander Levy with the Mobile Police Department. Our whole goal is to bring forward the much needed conversations that we need to have in our community about all aspects that improve public safety, and the mental health co-response is a huge piece of that.
And of course, we are heavily partnered with the National Alliance on Mental Illness local chapter and state chapter as well. And we participated in a Mardi Gras parade last year for youth violence prevention. We do activities in the park. That's the mayor between Commander Graves and myself. And we put him through some training.
Yeah.
So at Intercept 1, all officers receive a 4-hour mental health in-service training annually that we put on together. And we also do the 40-hour CIT course for officers. We don't do it for all officers because that's not the intention of the model, of course. And, then co-response is also at Intercept 1. And we have a forensic assertive community treatment team as part of our JMHCP grant. And that addresses those familiar faces that law enforcement comes in contact with and helps keep them out of the not only incarceration, but from calling 911 frequently or having 911 called on them, with a team that goes into the home and really, helps to keep them engaged in mental health services and stable. This is the command staff. We put them through some virtual reality training, and the mayor was actually here that day as well. And he got to see what it feels like to have schizophrenia and the police respond to you, and to be an officer and manage a call with someone with schizophrenia.
And it's really important to get buy-in from everyone, as many people as possible, especially your upper chain of command, to include your mayor. You saw the picture with the mayor in the photo with us. Having someone in place that can help actually be that cheerleader for these collaborations are extremely important. That's the thing that gets everything funneled down to your troops on the ground, but intentional engagement with the troops on the ground too is just as important, because they're the ones that you need to fully get the understanding of how important this work is to their everyday duties.
And of course, we ride out together frequently, like he mentioned just yesterday. We went on a joint response we often go on FBI related things, just police related things through dispatch. And this is, like I talked about, the forensic assertive community treatment team. All services are provided in the home, really focused on keeping folks out of jail But in the event that they do get arrested, we have services within the jail where we screen every individual with the brief jail mental health screening and the uncoat for substance abuse. And we have a case manager who's part of our Stepping Up initiative. We have 2 of them actually, who are in the jail every day and work to get those people back into treatment. And we'll talk about the other points of intercept, but that's the Stepping Up team. And we all believe in help, not handcuffs. And then at Intercept 3, the Stepping Up case managers are referring back to our forensic assertive community treatment team post-incarceration. They're making sure people are set up with appointments, that they receive high intensity case management. We have an assisted outpatient treatment team that is able to do civil court ordered outpatient treatment for those individuals who have a history of non-compliance. They often have interactions with law enforcement and really targeted on keeping those folks engaged in services and medication compliant. And specialty courts, we have a municipal mental health court, and Mobile is currently working on a countywide, like district level mental health court program. And peers are an important part of everything we do. There's throughout our crisis continuum, as well as all of our outpatient services. So that was the assisted outpatient treatment. At Intercept 4, just briefly, we complete the Ohio risk assessment on everyone leaving jail and help link them back into services, which include helping them with housing, benefits, and medication. And Intercept 5, we work with community corrections for those individuals who are on parole or probation, and help those folks get assessment, intervention, and treatment. And we operate day reporting centers in most major cities in Alabama, but this is the Mobile Day Reporting Center. Post incarceration at the state level, coming out to make sure that they're engaged in treatment on a daily basis and are compliant with medications and substance abuse treatment as well. And so all of those things working together result in the best practices of a system-wide crisis continuum of care. And Mayor, do you have anything that you would want to add? I know I spoke rapidly because
no,
I felt like
I think the biggest thing that we wanted to actually project in our conversation was just the importance of collaboration. It's extremely important, and we know that those in leadership are instrumental in making that happen. The hard work, however, comes in on the ground, understanding the importance of training and making sure that you are training the appropriate officers in co-response in the ways in which we need to really have people who are taking this responsibility as I get to, not that I have to, because anytime you have to do something, you get what you get from that. But when you get people to realize that they get to do this, then you get better outcomes.
And our commitment to changing things for the better in our city, we get as many people involved in that as possible. And like Commander Graves said earlier, having those stakeholders who can be champions of what you're doing is, essential to making the system work better.
Thank you very much, Dr. Gibson and Commander Graves. I really invited the Mobile team primarily for their work at Intercept 0 and 1, but as you can see, they have continued well beyond those intercepts and continue to build a fantastic continuum of services down there. The next grantee that we invited is Dr. David Geyer with the Kittitas County, Washington Jail or Sheriff's Office.
Excellent. Thank you, Justin. And I think a nice segue from the Mobile folks is I too work for a community mental health organization, and I'm partnered with our Kittitas County Jail. Unfortunately, our admin lieutenant couldn't make it today, so I will try my best to translate his slides here. So let's see if I can. Oh, okay. I might be able to share the screen now. Let me know if you can or cannot see that there.
We can.
Fantastic. So Kittitas County Jail, we are located in central Washington, Ellensburg, Washington. I-90 meets I-82. We have this sort of interesting combination of thoroughfares where we get a lot of folks from a lot of different places. And so we're a relatively rural area, smaller jail, 208 bed capacity. But we get a lot of folks coming from other places too that happen to, as we're talking about this intercept, engage with in our communities. So we offer a lot of services to a lot of folks that may or may not be local residents here. I think an important piece to what Lieutenant Button kind of shared with me as I came onto this program is really their mission, the verbatim here, this infrastructure and agency culture to enable us to provide the same level of service to our community that we would our own families. It really is in this rural setting, you know, these are not just people in a jail, these are community members, these are patrons of our community, and how can we best serve them, help them, however that might look. He will talk about, you know, what we had been doing wasn't working. And in a jail sense, you know, this is one of those jails that was built in the 80s. Lock the door, turn the key, walk away. And that wasn't working. That wasn't helping build a healthier community. And so admin here, starting in 2018, we had a different kind of phase of leadership, and they wanted to provide that better community care. And they also wanted to, as they say, you know, build longer tables and lower walls. And in a jail setting, you know, outside of the figurative speech can be a difficult thing to do. However, they started letting us in. They let us, our community partners in. So I work with community mental health. We have a number of different agencies involved. I think that might be on the next slide there. So again, doing the right thing for the right reason. We want to help these folks. We are a part of a continuum of care on this intercept model. My focus in this role is the folks that are incarcerated here. Yes, I work with our crisis team. Yes, we work with behavioral health courts. We work with, you know, reentry planning and that sort of thing. But again, you know, what are the constitutional mental health level of care? But then also, what's the best practice? So that's something that I've been trying to bring into this program. What are the best practices that we can implement in a jail setting? Developing these relationships with community partners, bridging the gap, all these wonderful things. I really love seeing, again, what the folks in Mobile, Alabama are doing. So really awesome to see the continuum of care. I'm going to, again, just kind of talk about what we're doing here in this jail. So we have, again, a number of different pieces. Medication-assisted treatment, which includes our hub and spoke program. So we have folks that come in and screen people for opioid use disorder. They can talk to a provider day of, oftentimes, to engage medication-assisted treatment, Suboxone for opioid use disorder. Hope Source is another agency. So again, a combination of different agencies. They can work on reentry, housing. Second Chance, I think, is another maybe EJA program, maybe a variation of that. So again, we have other partners with similar aspects coming into this together, trying to help these folks. Merit does our substance use treatment assessments. We have other community, you know, organizations that help with peer support. Again, all these things that we keep hearing, we're implementing this, especially over the last, you know, couple of years since 2018, seeing it now develop and kind of have this well-oiled machine. Somebody walks in the door, they're going to encounter all of these, if not more, services. I mean, we're also not including like just standard medical services, things like that. They're going to walk in. I kind of think of that picture of that community center. You know, a jail doesn't quite look like that, but you're going to walk in and have access to a number of different services when you walk into this jail. Myself, I guess, would be the last piece there with the behavioral health therapist screening assessment. So somebody comes in the door, they're going to engage with one of us pretty soon within walking in the door. Yes, they have to do their jail booking process, but we will also engage them hopefully within, you know, hopefully within 24 hours, we will have some sort of engagement with this person. And then we can either help advocate and make those referrals to these other agencies to have them then come into the jail, And again, this isn't just like a phone call to somebody. They're going to come in and meet with this folk, maybe with myself. Maybe they'll come in and meet with the client separately, you know, so we have this combination of services together. With this funding, we want to keep going, right? We want to keep building above and beyond. There is this larger context, the sequential intercept model. I really do believe too, as well, that if we provide more treatment in this setting for the folks that do happen to come to this institution, that then they'll even be more able to engage in reentry planning. Maybe they're, I can tell you, I have numbers related to, not on this slide, the folks that we can treat that won't get tied into the competency restoration cycle of events and can reduce the number of days they stay in a jail setting. So I want to double down on the kinds of services that we're providing here. Some of the things including, I'm working with a group out of Texas Tech, Changing Lives, Changing Outcomes, Dr. Robert Morgan, and one of his colleagues is doing a 9-session group therapy model to address R&R risk need responsivity model of care for criminogenic risk and then also mental health issues. So we are addressing these things in group therapy, in one-on-one therapy. We're doing case management, tying in all these other services, reentry planning with all these other services. And then also that warm handoff. We're a small community. I might walk somebody over to probation. I might walk them over to our community mental health agency. Or, you know, maybe I'll follow up with them the week, you know, a week after they leave jail and just see how they're doing and engage them in those services. So that's sort of the whole picture of what we're doing and hoping to build with this funding. So we're very grateful for that. And that is the end of my slideshow there. I will stop sharing. And yeah, thank you, Dustin.
Yes, thank you, Dr. Geyer. Fantastic presentation. And again, great to hear about the work that you and your team are doing, not only in the past, but how you're continuing to use this funding to be able to move forward. Next up, we have the City of Philadelphia, specifically focused on their reentry programming with Stephanie Turner, Kelly Greenwald, and Jacinta Reason-Johnson. And Kelly, I think, is the master of ceremonies for the screen sharing.
Yes, give me one moment.
Absolutely.
Can everyone see the screen?
We can.
Awesome. Stephanie, want to go ahead and introduce yourself?
Yeah, so before we get started with our presentation, I want to do an introduction and then I'm going to hand it off to the external partners that's going to also be sharing. So my name is Stephanie Turner and I am the program manager for the Justice and Behavioral Health Division under Department of Behavioral Health and Intellectual Disabilities here in Philadelphia, Pennsylvania. I manage the Alternatives to Detention team, which we partner in conjunction with the Yes Care team that you're going to hear from very shortly. The Alternatives to Detention team coordinates and implements reentry planning for reintegration back into the community. I'm going to send it over to Kelly so she can do her introductions, and then Jacinta will be presenting our presentation for this group.
Awesome. Thanks, Steph. I'm Kelly Greenwald. I'm based out of Philly with Yes Care out of the Philadelphia Department of Prisons. I was actually hired through this awesome grant. So I hope you all enjoy. Jacinta, I want to go ahead and take it away.
Hello, everyone. My name is Jacinta Reason-Johnson. I am the Behavioral Health Reentry Coordinator at the Philadelphia Department of Prison. I had been with the jail for 6 years, so I've been a part of this program for a while and working with our community partners. And what I heard from the other presenters is the big word collaboration, and that's what we've been doing with this grant. So the Alternative to Detention program, as well as Yes Care's reentry team, seeks to enhance the reentry process for incarcerated individuals. We also, individuals diagnosed with serious mental illness returning to the community from Philadelphia Department of Prison. The process consists of coordinating services designed to help the incarcerated mental health population adjust to life outside of prison by providing wraparound services. Those services include, but are not limited to, screening and linkage to mental health/substance abuse treatment programs, activation of insurance, housing assistance, case management, and peer supportive services. During this process, YesCare has been able to collaborate with ATD navigators, prevent duplication of services between each provider. We have also been able to discuss the different barriers faced behind the wall in the community when coordinating services. Our team works primarily with our FMI pretrial population, and one of the barriers were able to highlight were knowing when the release dates from corrections. With frequent communication and data collection, we have created tools such as the post-release support service form, which allows us to gather the most updated contact information along with other areas of support the client has shown interest in. This overall collaboration has created a warm handoff between those behind the walls and other community providers to help our client more efficiently once released. We make this collaboration successful is the trust and respect for each other's roles within the program. The reentry process is essential in reducing recidivism rates and helping formerly incarcerated individuals successfully reintegrate back into their communities. On our PowerPoint, we highlighted our post-release support form. This helps the collaboration because it allows the different disciplines that's a part of YesCare and the ATD navigators to collect information in order to create a proper reentry plan, which Stephanie team does. Kelly and I are behind the walls. We work directly with the incarcerated persons. We then transfer that information to Stephanie's team, where Stephanie's team then creates a discharge plan for the individuals and coordinates them to different providers in the community based off of the needs of the client. Just like the other grantees that explain, like I think we have similarities when it comes to the collaboration, the different services provided to the clients. But our biggest thing has been the warm handoff, and I heard that a lot too. Creating a warm handoff between the different disciplines, the different providers has been really helpful for this process.
And then I would just add that the collaboration with the YesCare reentry team has just been the biggest thing. So we have a team that's behind the walls. Then we have our community team with the Alternatives to Detention that's doing these doing the reentry planning with the information that's provided from a lot of information that we receive from PDP, from Kelly and Jacinta. And then we have regular meetings. We're always discussing, we're coming up with new ideas, we're collaborating on different individuals that we're providing services for, with the hope that, like Jacinta said, that warm handoff piece back into the community for reintegration. So the services goes on and on and on. There, like we do housing, we do treatment, which is very, very important. Medication compliance. The list just goes on and on, just like everyone else that presented prior to us presenting.
Awesome, thank you.
All right, thank you very much. And I'm also hearing a lot of similarities as all of our grantees are sharing. They're focusing for this webinar on some of those particular intercepts, but each of them is doing work before, during, and after the intercept that they're focusing on, which is fantastic. And last but not least, looking at kind of that community corrections piece, we're joined by Dr. Gary Cuddeback, representing the University of North Carolina at Chapel Hill for the grant, but currently with Virginia Commonwealth University. So Dr. Cuddeback, the floor is yours.
Okay, thank you. I'm the only thing standing between the group and happy hour here. So let's see, Dustin, yep, I do have screen sharing. And let's try that. All right, Dustin, I can see you. Give me a thumbs up if you can.
Yep, we can see your screen.
Great. And dare I try to put into presentation mode? Let's see. Bear with me. No notes. How's that? Dustin, good?
Not in presentation mode, but we can still see the slides at least.
Okay, good. So it's not in. All right. So anyway, all right, here we go. Let's see if I can fix this. Hide presenter view. Okay. So thank you. Delighted to have an opportunity to talk about my project. This is something that we started when I was at UNC, and now I'm at Virginia Commonwealth University, as Dustin said, rather. And I'll talk a little bit about the probation side and some work I've been doing over the last couple of years with specialty mental health probation, and then most recently specialty mental health probation and supported employment. So as we all know, on any given day, there's about 37,000 individuals with serious mental illness in our network of state hospitals across the country. And juxtapose that with over 250,000 individuals with severe and persistent mental illness in prisons, 130,000 on any given day in our 3,400 jails across the country, and almost 1.5 million on probation and parole, so community supervision arrangements. The red oval is around jails because, as we all know, those are quick turnaround, short-term stay facilities. There's about 14 million admissions to local jails annually. Probably 10 to 14% of those are admissions involving individuals with severe mental illness. So probably a million, closer to accurate figures with the number of folks in jails at any given time. And as a response, as we all know, the justice system has developed its own set of interventions and policies and protocols to manage better encounters with individuals with severe mental illness. We've got crisis intervention training for police. We've got mental health courts. We've got treatment and programming in jails, treatment and programming in prisons, and then mental health probation and mental health approaches for supervising individuals on probation with mental illness. So individuals with mental illness in general have a lot of challenges, including stigma, substance use, homelessness, chronic physical health problems, and you layer on involvement with the justice system, and it becomes that much more difficult to advocate for, to serve, to engage, to treat, and so forth. So a lot of problems to begin with, and then layer on justice involvement, it adds even more complexity to serving and treating individuals with severe and persistent mental illness. These are some data I collected from a study I did recently of mental health probation. And this was the results of a questionnaire focused on traumatic lifetime experiences. And really what I want to show here is the yellow bar, individuals with severe mental illness on probation. There's 204 of those in my study. And 80% of those 204 individuals experienced a physical assault in their lifetime. 61% experienced an assault with a weapon, 50% men and women sexual assault, 40% life-threatening illness and injury. 90% of the sample experienced one interpersonal traumatic event. And then half of the sample, 50% of this sample had met diagnostic criteria for post-traumatic stress disorder. Now that figure in the general population is 3 to 4%. Among individuals on probation with severe mental illness, in this sample at least, it was 50%. So from a treatment provider perspective, from community-based mental health, the undiagnosed, untreated trauma is a significant issue in a variety of ways, engaging, serving, treating, and so forth. So this is an alarming finding, the level of trauma experienced by this population, which probably doesn't come too much of a surprise to anyone here on the call. And then also the same sample asked about unmet needs. And if you think about probation, as we all know, probation comes along with requirements, right? Get a job, safe and stable housing, maybe get into substance use treatment, maybe finish a GED. Those things are very difficult for individuals with severe mental illness to do. And then layer on top of that unmet basic needs. So of this sample of 204 individuals, almost 70% had unmet food, clothing, shelter needs, had 70% medical needs that were unmet, 70% dental needs that were unmet. 68% or so needed outpatient mental health, but weren't receiving it. 70% needed medication, but weren't receiving it. Over 70% did not have a driver's license, and trying to get around from point A to point B without a driver's license, particularly in rural areas where the majority of our people on probation and parole are, is extremely difficult. 60% lacked housing, and 62% had no Medicaid or no insurance. So layer on all the problems I suggested earlier: stigma, social isolation, physical health problems, substance use, unemployment, lack of housing, and then put that together with the trauma, plus all these unmet needs, makes a very difficult population to serve, as we all know. So these are findings from a series of studies that I've done over the years. Also, as you know, criminologists, sociologists like to talk about criminogenic needs and risks, which is not something that the mental health community necessarily thinks of. But here, these are data from North Carolina. Individuals on probation. The green bar are individuals on probation without mental illness. The red bar are those with mental illness. And you can see across the board, individuals with mental illness have higher levels of these criminogenic risks that are all commonly known. So mental illness, as you know, is not a criminogenic risk, but certainly it seems like there's a synergy, meaning individuals with mental illness have elevated levels of these criminogenic risks, which makes it harder on the criminal justice side as well as the mental health treatment side. Okay, so what have we done about this? Before I get to that, it's not just about treating mental illness. And again, this is not something that is unknown to our group here, but I like to say in almost an annoyingly oversimplified way, people need a bed, a buddy, and a job, right? We all need those things to thrive in our communities. And individuals with mental illness who have justice involvement are no different. Let's get them a bed, a buddy, and a job, safe and adequate housing, pro-social support, supported employment arrangements, in addition to treatment of mental illness and substance use, right? But not just treatment for mental illness and substance use. It's about these other things that we all need, and individuals with mental illness are no different. So a couple of things that I've been working on both in North Carolina and since I've been here in the state of Virginia. One, in North Carolina, we created mental health training modules for all probation officers. And now it's policy that new probation officers must go through basically a mental health 101, mental health first aid. So these are just 6 of, we're now up to 10 different training modules that all officers must go through when they become probation officers. The first one is a state-specific risk and needs assessment instrument that is focused on mental health. So that's what that is. Then severe mental illness 101, psychiatric medications, PTSD, personality disorders and other disorders, crisis response and local services. So what is an ACT team? What is case management? How do I get a hold of a supported employment service? And then self-care for probation officers was one of our more popular modules. The rates of suicide among probation officers, particularly those recently retired, is relatively high compared to other professions. So I did a simple pre-test, post-test study and found that officers who participated in these modules did have an increase in mental health knowledge and a decrease in stigma perceived towards individuals with mental illness, which is good because there's evidence that the less stigma you feel towards someone, the more likely you are to help that person. So these are the training modules we've done as a part of our BJA funded work, supported by Council of State Governments. And then the other thing we've done, and I'm just wrapping this up, is we've combined specialty mental health probation with individual placement support, supported employment. So an evidence-based supported employment intervention embedded in a specialty mental health probation service. So specialty mental health probation typically includes these 5 elements: caseloads of probationers living with mental illness exclusively, reduced caseload to about 40, ongoing officer training, problem-solving supervision orientation, and greater interface with external resources. We've added in North Carolina ongoing clinical supervision with a licensed clinical social worker. So our LCSW meets monthly with all of our specialty probation officers. We're now up to 38 counties across the state of North Carolina. The state wants to do 100 for each county, 100 counties in North Carolina. So we're not quite there yet, but making great progress. And then what we've done is we've added a 1.5 FTE supported employment service, because one of the primary requirements of probation, as we all know, is you get a job, right? And people with mental illness really have a difficult time doing that. So the idea was to add this evidence-based employment service that would work closely with a mental health probation officer. So we've learned a lot doing this. We found that in many cases, people new to probation who have severe mental illness, they first get on, they are not ready to work. They have a lot of other case management needs that have to be addressed. Remember the slide that I showed a few moments ago, all the basic needs that individuals on probation with mental illness lack. Those have to be addressed first and foremost before they can even think about getting a job, which, as we all know, probation doesn't typically wait, right? We're not going to wait for you to get all your issues resolved and things lined up before we ask you to start meeting the requirements of probation. So that was a very important lesson to learn. So if I were to adapt the IPS model, which is an evidence-based practice, I would add a 6-month pre-case management service component to it before even trying to get into the employment aspect. Very difficult to integrate a mental health service into a criminal justice setting like that for lots of reasons, but different mission, different protocols, policies, personnel issues. So we learned quite a bit trying to do this integration of a supported employment intervention. And we didn't have, not every one of the important features of supported employment is that an individual who's receiving that service has to be connected with a mental health agency. And the idea is that the supported employment service and the mental health agency would be coordinating care. But in many cases, as I said, those were unmet needs. So the probation officer was often trying to connect someone to a mental health service while the IPS service was going on. So made a very difficult setting in which to try the service. But we learned a ton and know a lot about how to integrate a supported employment intervention in a probation, mental health probation unit. And I think that is it. Thank you. I'll stop sharing.
All right. Thank you, Dr. Cuddeback, and thank you to all of our presenters. We do have about 9 minutes left for any questions and answers that you all have. Again, due to the number of participants here, it's probably easier if you would either ask your question in the chat or use the question and answer function. And we did have one comment that I believe was directed at Commander Graves and Dr. Gibson out of Mobile. Have you incorporated peers and or family support into your mobile response process?
Yes, we do have a peer that goes out with our crisis response team, and we have peers in our behavioral health crisis center, and also one of our stepping up case managers is a peer. The more the better.
And for any of our other grantees, are there ways that you are also implementing peers into the work that you're doing?
We now have
So-
peers coming into our jail and meeting with clients specifically for SUD, and then hopefully in the future, also regarding mental health issues and reentry. So there's a number of different ways we're hoping to implement peers in the near future.
So we definitely utilize peers services. We recognize the importance of having that individual that the folks we service feel comfortable with working with that shared experience that they have, shared histories that they may have in common. So we recognize that peers are extremely important and definitely utilize them.
Fantastic. And James asked if it would be possible to get contact information from the presenters. I will confirm with the presenters and make sure, but then if that's okay, when we send out the follow-up email with the link and PowerPoint and everything, I can also be sure to include contact information if anyone does have additional questions or wants to follow up with grantees individually. Other questions that folks have? Well, we've got all kinds of experts here today. I kind of feel like we've had 5 separate presentations all rolled into one, starting off with Haley and then all the good work that's going on out in the field. But other questions that anyone has at this time? Well, if anyone is still thinking or typing, Carly, if you would go to the next slide. When we send this out, there's also a few additional resources that will be included in addition to the slides that Haley shared with her links. Also have additional resources about the sequential intercept model from Sams's Gain Center. I also included a Council of State Governments Justice Center publication on trauma-informed approaches across the sequential intercept model. And lastly, there's a guidelines for managing substance withdrawals in jails. That's from the U.S. Department of Justice, Office of Justice Programs, Bureau of Justice Assistance. So definitely a lot of information contained in the links that everyone has provided today as well. And looks like Joy had a question in the chat wanting to know more about virtual reality trainings.
That's always
Yeah.
a popular topic and one that we love to talk about.
Absolutely.
You want to take that?
I can. We'll be more than happy to really share with you if you want to reach out to us about the virtual reality headsets. We're actually going a little deeper, if all works in our favor, to create a virtual room that will not only allow you to experience the virtual reality aspects of engagement, but also to tap into those senses that we all have when we're actually out in the field. I mean, so we're talking about including smell and touch. And the good thing for us is that we do a lot of collaborations, and we have a tech partner that works with us very closely about a block from my office. And more than half of what we need to make this actually come to fruition, they already have. So right now we're just hoping that we get the funding that will support the rest of it.
And we use the Axon headsets, and they make such a huge difference in training. So the first portion of our annual in-service training is the death by PowerPoint, of course. And then, we have dead eyes for, that portion of the training. And then they put on those virtual reality headsets and they're like, oh, that's what you were talking about.
Yeah.
And that empathy really comes out, and it makes a huge difference, and they walk away feeling much more knowledgeable.
And I think that's the key. I think that's the takeaway, is that sense of empathy that you don't typically get in a classroom setting where you're just being lectured about it. When you get a chance to truly experience it in such a way that you are making decisions in real time in that scenario, and then being able to see all the different aspects of it, it really makes it relatable to officers, is what we've seen. And when we've done the training, we always ask that question, what did you gain from it? And they always come back with empathy, understanding that it does not keep you from doing your job. It just gives you more understanding of what it is that you're doing in that particular scenario or situation.
Thank you for that. And Carly, would you go ahead and advance to the last slide? I think we have time for one more question here, but also wanted to give everyone my contact information as well. If there's additional follow-up, definitely feel free to reach out to me. But the last question was, do you have a crisis stabilization and response unit for mental health emergencies?
We do. Yes.
All right. Well, in our last minutes here, because I do want to be respectful of everyone's time, thank you again to every one of the presenters, to Haley, to all the grantees for taking time out of your day to share your expertise and your experiences. The chat has a whole lot of kudos and a whole lot of thank yous for everyone who's been here today. I also wanted to thank Carly Salon, project manager with Kansas State Government's Justice Center, who's been hovering in the background and running mission control, letting people into the meeting, helping make sure we get recorded and running the slides for everyone. And also thank you to all of our attendees who were able to be with us today. And again, thank you for your questions and thank you for your feedback in the chat. We will go ahead and stop recording and wish everyone a happy Thursday afternoon. Thanks again for coming.
Thanks.